Selam እንዴት ናችሁ? I think we're having some audio issues because Sanite is not hearing us at all. Can someone from the attendees tell us if they're able to hear us or not?
They are saying that we are listening.
You can hear. Okay, good.
Yeah.
Good. Okay. Good. ሰላም እንዴት ናችሁ? ዛሬ የተገናኘነው እንግዲህ የጤና ወግ continued medical education የሚባል ፓርት አለው እና በዛ continued medical education ውስጥ ዛሬ ስለ palliative care, what is palliative care in general, ምክንያቱም there's a big gap when it comes to understanding what palliative care is. And now to help bridge that gap, today we'll be talking about just giving an overview of what palliative care is, what services that it gives underneath palliative care. And then there's a major misunderstanding between palliative care and hospice care. Now, what's that big difference? With us today, Dr. Ashanafi Beza. He's a pediatrician. He's a senior technical advisor and also a Medical Services General Directorate at the Ministry of Health of Ethiopia. And then Selama Itselemon, she's a National Palliative Care Coordinator in Ethiopia. She's an expert in public health, and she's a team leader in Pain-Free Hospital Initiative that's currently undergoing in Ethiopia now. I will be starting the educational piece of it, and I'll be sharing my PowerPoint slides with you. And then we can proceed. At the end of our discussion, we will be accepting questions. So that's how we're going to go about it. Okay, I'll be sharing my screen now. Okay, so can you all see my screen?
Of course, yes.
Good. Okay. So once again, the reason why we are here together today is to discuss about palliative care and just give introductory lesson about palliative care for all professionals. So who's our focus group? Basically anybody who is practicing medicine. It could be an internist, it could be a critical care specialist, it could be an oncologist, a nephrologist, a cardiologist. I personally believe that everybody needs to have a skill set of palliative care. So this is meant for everybody who has an interest in practicing quality medical care. Okay. Who am I? My name is Radiat Gabayo Balalahun. I'm a board certified internal medicine. I'm board certified in internal medicine, and I'm also a specialist in hospice palliative care, and currently doing fellowship in hematology oncology at Wake Forest Baptist Health. So when it comes to palliative care, when you introduce palliative care to anybody, it could be a medical professional and it could be a patient, there are three reactions that you will get. One is there are people who actually know what palliative care is. They have practiced this, they've been in it, so they understand what palliative care is. And there are people who think, especially in the medical field, there are people who think they know what palliative care is, but don't really understand the facts and the details that it has in it. And then there are people who have never heard of it. Personally, I was in the middle here as a number 2, even going into the field, having practiced as an internist, having been through residency, and also having been a medical student. I thought I understood what palliative care was, but really didn't have clarity when it comes to that practice. General facts, and most of the facts that I'll be mentioning today are US based because I am trained here in my sole practice as a palliative care person. It's just here in US. So the facts that I'll be mentioning are US based. And later on, Dr. Ashanafi and then Salamawit will be telling us what things are being done in Ethiopia. So the fact is that more than 80% of Americans, when asked, actually want to die at home. So they want to be surrounded by family. They want to preserve their values and their dignity, and they want to pass at home. But when we come to the actual fact, only 25% of those people actually pass at home. So you can actually see how wide the gap is there. And there's this general misunderstanding, like I was mentioning earlier, within the medical professionals and also within the patient or the public, that when the name palliative care is mentioned, that somebody is very near end of life or somebody is actually actively passing, which is really not true. So anybody can actually qualify for palliative care services when they get diagnosed with something that is chronic and with something that we know is a progressive disease. Palliative care doesn't equate to passing actively or like being in your end chapter of life. So according to the Center for Advanced Palliative Care Services, palliative care is a specialized medical care for people living with serious illnesses. It's a type of care that is focused on providing relief from symptoms and stress of their illness. And the goal of palliative care overall is to improve quality of life, not only for the patient, but the family. So in other subspecialties, usually what we focus on is actually treating the patient, or we focus more on the diagnosis, and the family just isn't involved in that care. But when it comes to palliative care, there is this wholesome care that we focus not only on the patient, but also the family gets involved on the care, because there is a psychosocial component when it comes to treating a patient's needs. So palliative care is provided by a specialized trained team of doctors, nurses, and other specialists. So this is to mean that it doesn't have to be only physicians who practice palliative care, but also nurses. There are social workers who are trained in palliative care, and there are chaplains. In our country's system, it could be spiritual leaders that could be involved in the care of the patient, because we all are spiritual beings as much as being physical beings. So these specialists actually work together with the patient's other doctors to provide an extra layer of support. And I will mention this in detail later on, that you don't have to lose your other doctor. So you can keep seeing your other doctors while palliative care is providing this extra layer of support. And again, another definition from this institution is, hold on. Palliative care is based on the need of the patient. It's not on the patient's prognosis or diagnosis. So we focus on what makes the patient suffer. Is it pain? Is it nausea? Is it vomiting? Do they have any financial stressor? Do they have any psychosocial needs? Rather than just focusing on their numbers or their kidneys or their cancer. It's appropriate at any age and at any stage in a serious illness, and it can be provided along with curative care. And this is a very important thing that we have to nail in our heads, and also nail in the heads of other medical professionals, that if someone has a serious and ongoing illness, whether it's diagnosed today and it's at an early stage, let's say stage 1, people do qualify for palliative care services. Along with their curative care. That means you don't deny them their curative care, whether that is a chemotherapy or a radiation. They keep, getting those cares alongside their palliative care. Another definition by the palliative.doctors.org website, palliative care is relieving or soothing of symptoms of a patient or a disorder while trying to maintain the highest possible quality of life for the patient. So, as a disease progresses and as we keep treating someone when they're with their disease progression, let's say, usually, we keep mentioning cancer because majority of the cancer patients are the ones that would benefit from palliative care services. There comes a time where our aggressive intervention actually causes more harm than good. So when it comes to palliative care, our highest priority is actually maintaining that quality of life, preserving that patient's dignity and respect, all the way through their death or the end of their life, rather than just keep doing aggressive care. Yeah. And many people, again, mistakenly believe that you receive palliative care only when you can't be cured. And again, that is not a true fact. And actually, palliative care can be provided by one doctor while other doctors work with you, trying to cure your illness. So again, symptom management is what palliative care does, while other people oncologists can keep giving you chemotherapy. You can keep seeing your radiation oncologist to get to receive your radiation. You can have surgery while having palliative care. And this paper that I put at the bottom of the slide is a very important paper that came out in 2010. It was published in New England Journal of Medicine. So what they did was they enrolled these advanced cancer patients, and specifically in this case was advanced cancer, lung cancer patients, and then small cell lung cancer patients. They enrolled them to an early palliative care intervention along with their treatment. So what they found at the end of the study was that people who actually received early palliative care actually lived longer. They preserved a better quality of life. They had a better mood at the end of the study, despite having less aggressive care. And this is a very important paper, because we tend to believe as clinicians that the more we do, the better the outcome, but not really. What this is telling us is these patients, although they were really advanced in their cancer, although they didn't get all the chemotherapy, all the radiation, all the surgical intervention, whatever was indicated in their care, they actually lived longer as compared to those who actually received all those interventions. So after this paper came out, palliative care got a lot better acceptance here in the healthcare community. So as a clinician, because there's a lot of misunderstanding, again, not only in the public or not only on, yes. Yeah, so not only not only in the medical professional side, but also there's a lot of misconception, not only in the patient side, but also in the medical professional side. So you as a clinician, how do you introduce it to your patients? Now you have a patient who has an advanced disease, you have a patient that has end-stage renal disease, advanced COPD, advanced HIV infection. I mean, there's just a lot of chronic progressive disease that we can't cure in this day and age. So how do you introduce this concept to your patient is very important when when you're working with this background understanding. Hold on, I have to answer. My voice has an echo. Is it okay if I mute the other participants for now? Okay, how about now? I'm hoping that it won't have an echo. It is clear. Okay, thank you. Thank you. Okay, so how do you introduce that concept when you're working against this misconception that palliative care means, palliative care has interpretation of end of life, or you are dying tomorrow, or you're dying in the next couple of days? So you introduce it as an extra layer of support. While your kidney doctor is working with you, while your lung doctor is trying to improve your breathing, and while your cancer doctor is giving you your chemotherapy and radiation, palliative care can work as this extra layer of support, because we have the time to sit down with you, discuss what your symptoms are, what your psychosocial problems are, what your financial problems are. Palliative care works as this extra layer of support, supporting you, managing your symptoms while other physicians are working on your symptoms, okay? Or your illness. So that's how you can actually introduce it to your patients. Okay. when we discuss about care, as medical professionals, the care that we provide is either curative, which is probably like more than 90% of the care that we provide is a curative care, which focuses on curing a disease or prolonging somebody's life. So majority of the care that we train for, whether it's in surgery, in internal medicine, pediatrics, or anywhere else, it's focusing on curing an illness or trying to prolong someone's life. What palliative care focuses on is while the other professionals are trying to cure someone's illness or trying to prolong life, palliative care focuses on making someone comfortable, maximizing their quality of life while other treatments are being offered. And then we'll discuss more about hospice care. And hospice care comes into the picture when cure is no longer possible, okay? So we know that that person has a prognosis of 6 months or less. We being humans and just having that estimate, knowing what we know, if we think that somebody has a life expectancy of 6 months or less, we offer hospice care. So this is the spectrum of care that every medical service actually lays in. It's either curative care, which is most of the care that we know. Palliative care can work as an extra layer alongside curative care. And when we think that curative care is not an option, we think about hospice care. Again, this is a very important model that was proposed by the WHO in 1990. You can put any chronic progressive illness into this diagram, and then it will follow this continuum. See here that this is a date of diagnosis, and you can name this as end-stage renal disease, or like you can name this as CKD stage 4, or you can name this as a stage 1 cancer, breast cancer, colon cancer, you name it. Initially, I mean, if it's diagnosed early, obviously, the chance that this could be cured is high. But as we go along the spectrum, the chance that someone will be suffering more from symptoms and will benefit from curative care actually minimizes. And the fact that someone will benefit from palliative care gets really maximized. And this goes up until the time where we think someone has a prognosis of 6 months or less, and that is when they will qualify for hospice care. Here where I practice, after someone qualifies for hospice care, there is what we call bereavement care. So after someone passes, okay, with a serious illness, if they have enrolled in hospice care, the family, whether it could be a spouse, it could be children, it could be parents, it could be, brothers, sisters, they would benefit from bereavement care, which continues up until 13 months, because they have to pass the 1-year anniversary after someone passes. So they will get that coverage of bereavement care 13 months after someone passes. So this is a beautiful diagram that shows you, you can put any illness in there. You can put any, of course, it has to be chronic progressive disease, and then it will follow this spectrum. So a lot of things that I mentioned here. Yeah. So both, there are some overlaps between palliative and hospice care. Is both actually ease symptoms. They try to ease suffering, of course, and they focus on quality of life. It could be in days, because, there are people who get diagnosed very late in the stage of the disease, so they will have days in front of them. But there are people who get diagnosed very early on, and they will have years in front of them. And we focus, again, palliative care and hospice care together, they focus on the whole patient, and they try to support the whole patient and their families. And it's composed of a multidisciplinary team, which is like nurses, like I said, social workers, and chaplains, okay, and physicians. So what do we do in palliative care? We do a lot of symptom management because patients actually suffer because of symptoms. The main component of what we call symptoms is pain. People suffer from pain most of the time. And we do a lot of goal of care discussion. I'm going to go in detail about each one of them, so I'll just touch them here at goal of care, which is like, what is their understanding of their disease? What does their disease look like in months and years to come? What are the treatment options? And with each option, what are the gain and what are the losses? So we sit down and discuss that with each patient. We do advanced care planning. So if there comes a time that the patient can't decide for themselves, who is going to make those decisions for them? At time of emergency, which is like if their heart stops beating, do they want cardiopulmonary resuscitation? Is that something that they want? So those will be things that we sit down and discuss. We try to advocate for patients that they're not really suffering through the process of treatment. Yeah, and we actually go the extra mile. We think outside of the box, and we work on legacy project. This is, to me, like if you sit down and communicate with a patient that they are going to pass in the next months to years, or it could be weeks to months. I'm sure each and every one of us have some things that we want to leave for our family. So that's what we call legacy projects. Sometimes it could be a child that could be passing, and family would want like a picture, pictures that are made, and beautiful albums that they want to make out of their children's pictures. And it could be your spouse, it could be things that they want to write down for their loved ones. So we really work together with that family to try to leave a legacy project. Okay. So what do we mean by symptom management? So when we say symptom management, there has to be a distinction that we have to make between pain related to other conditions. I mean, because someone has a chronic back pain, which is a very common complaint, they don't qualify for palliative care services. So when we provide pain management, when we're talking about symptom management in palliative care, we are focusing on those patients that have serious life-limiting conditions. So when it comes to that, palliative care physicians are experts when it comes to narcotic use. Because pain is undertreated most of the time. There is this misconception that is within the medical society that narcotics get abused. Yes, that is true. Narcotics get abused, but there is a reason why narcotics are out there, and they just have to serve their right purpose, which is treat the pain of those who should be treated. So cancer patients, usually their pains are not treated. And if they have palliative care as an extra layer of support, we make sure that they are on the right dose of medication. And we have different formulations when it comes to narcotics. We have liquid solutions that people can use in their home setting with very small volumes. So symptom management is very big when it comes to palliative care. There are also non-pain symptoms, nausea, vomit, especially if someone is on chemotherapy, if they're receiving radiation. People suffer a lot from constipation, and we, as the other medical professionals and medical professionals and other subspecialties, it's not that they don't have an understanding of constipation or how to treat it, but they have other things they're dealing with at that point. But the patient would be suffering from simple things that you can treat if you have the time to sit down and really ask the patient. People will be experiencing fatigue. They will be, of course, anxious. There are a lot of mood swings that you can get when you're dealing with a serious progressive illness. And also delirium, as people are really nearing end of life, there is what we call terminal agitation. People might be suffering from different neurological symptoms. Another important thing, if you're dealing with a young person, especially diagnosed with a serious life-limiting illness in their 30s, in their 40s, there is what we call existential angst, which is other pain, and another name for it is total pain, which is, it's not only physical pain that actually affects or makes the patient suffer, it's other things around the physical pain. Why me? There is a spiritual distress. Why is this happening to me? Financial issues. A lot of people are they could be supporting their family at that point. There could be a lot of psychosocial stressors. If we have that extra time, 30 minutes, 45 minutes, if you sit down and speak with a person, there is much more to a person's suffering that that doesn't need medications. It just needs time and other resources, and your social workers and your spiritual leaders, the chaplains, would actually play a major role in resolving these what we call existential angst or total pain. Another thing that we do is goal of care. One is, what do you or your family understand about your diagnosis? What does it mean to have this disease? What does a disease look like? How many % of those diagnosed with these illness actually get a cure? What is important to you? For some people, it's very clear that once they lose their independence, life loses meaning. So if your patient is like that, you really have to lay it down for them, and telling them that the procedure they're about to undergo, or the chemotherapy or the radiation or the dialysis they're going to undergo, is going to affect their life, is going to take away their independence away from them. And if that is not okay or acceptable to them, there are other options, which is just making someone comfortable. Yes, your days could be shorter, but you would at least preserve your dignity and value as you pass, because we all are going to pass at the end. So you have to offer aggressive care versus comfort care. We really have to be honest with our patients, telling them, yes, dialysis is an option. I'm just giving these as an example. Because common things that we see as cancer, end-stage renal disease, advanced COPD are the very common chronic illnesses that we deal with. So, but the patient and their families, they have to know that at this point, maybe we're not talking about a cure. We're talking about this, months or possibly years. So this treatment might actually make you bedridden. Would you want to proceed this way, or would you want to be just kept comfortable, knowing the fact that, just being kept comfortable means, yes, your symptoms will be managed with medications, but you'll be more, you're going to pass soon. So you have to ask them, how do you want to spend your time? Are you tired of coming back and forth to the hospital? There are people who get admitted to a hospital multiple times a year, and we just have to check in with them if the life they're living is actually acceptable, and if they want to stop at some point, palliative care needs to be involved, and then progressively they can enroll into hospice care. And you have to ask them, are they spending more time in the hospital or doctor's appointments? There are people who actually have 4 or 5 appointments in a week time, and they're spending most of their days in a hospital setting while they have a prognosis of months. And for these people, if you sit down and talk with them, maybe they're just tired of coming to the hospital. Maybe they're not really reaping the benefits of coming into the hospital, and they would rather just sit at home and just spend the rest of their time with their families, where palliative care can actually bring their medications there. And I'll talk later on as to where do we provide palliative care services. And another point, I really like this statement, is, medicine is a runaway train. We need to check in with our patients periodically to make sure we're doing right by them. So it's not only, at time of diagnosis, you have to keep checking with your patient to see if if what we are offering is actually bringing, lessening their suffering, at least, if it's really not adding to their suffering. Is it still informed consent? In medicine, usually we do consent as we get into a procedure or as we start a certain therapy. We don't periodically check in with our patients and see if they still have an informed consent, and that is very important. Is that what the patient expected? When someone has a tracheostomy, or when we're putting a feeding tube in someone's abdomen, before getting it and after getting it, are they okay with the procedure or the result? Are they okay with that? You have to check in with your patients. Is it too much for the patient? It gets too much sometimes, to be on the other side. And do they understand what has been communicated? Oftentimes, as part of the palliative care training, there is what's called communication training. There is this fact that we sometimes just explain things to our patients, not hearing back from them. Sometimes when you stop and ask your patient, just taking that extra 5 minutes, can you explain to me what I just told you? I just want to make sure that I am being clear. You'll be surprised. Sometimes they don't even catch 10% of what you have just said, but you thought you actually explained everything. So sometimes things could be too much for someone who's not in the medical profession. So we have to really know if they understand what we have communicated. Sometimes it could be like in more than, I mean, it might not be enough to do. I mean, it might not be, you might not gather that information in only one appointment, but in successive appointments, in multiple appointments, you just have to make sure that your patient is understanding what you're doing and which direction that you're going. And if that's what they want to go, because at the end of the day, the autonomy is theirs, you know, their body is theirs, and their family. And yeah, so it's the same thing, how much of the communication is clear and precise. Advanced care planning. So at some point, you know, if someone has a serious illness, there will come a time that they can't make decisions for themselves. And when that time comes, who do they want to make their decisions? Is it their spouse? Is it their child? We do what we call advanced, an advanced care planning, and people actually put it in writing where I practice. They put it in writing and then they sign it. It has to be witnessed by 2 people, and that serves as a document clearly stating what the patient wants when their end approaches. What kind of care do they want? Do they want feeding tube? Do they want chemotherapy? Do they want to be sent to a skilled nursing facility? These are things that we have to clarify with our patients when they get diagnosed with an overwhelming diagnosis, a serious illness. And advanced directives are living, breathing things, and we have to give them sunlight and attention. If we keep talking about these things, a lot of things won't be a surprise. And a lot of people won't die in a hospital setting. If you really ask your patients where they want to pass, a lot of people would want to pass in their home, surrounded by their families. If we keep discussing, you know, and having advanced care planning with our patients, assigning a decision maker, which is very important, so that we maintain the peace of the family, you know, after the patient passes. And also, do they want just compressions? That's another thing that we have to clarify with the patient when they're able to communicate their needs with us, when they have decision-making capacity. And what kind of care do they want? Some people will tell you, like, once I lose my independence, I just want to stay home. But of course, I don't want to suffer. I want to have my symptoms managed, so that you can assign a nursing team to go out and check on them, you know, once or twice a week, and check on their well-being and how well their symptoms are managed. And then they will pass where they want, preserving, you know, having their dignity preserved. This is just an example of a hierarchy of decision-making when it comes to code status, which is DNR, DNI status, or consenting for someone's medical or surgical treatment. So obviously, number one is the patient. If the patient is decisional, can make the decisions for themselves, autonomy purely is the patient's. And then sometimes people, like I said, with the advanced care planning, people will have this paper they sign, document they sign and witnessed by 2 people that designates a healthcare power of attorney. A healthcare power of attorney is what we call it. So that designated person, if the person has that, of course, next to the person would be that designated person. Otherwise, different states and different countries have their own hierarchy that they go by. If the patient does have never communicated their needs, it could be either the spouse when it comes to code status, and then sometimes the court assigns a guardian for that specific patient. It could be a child, it could be a parent, or it could be siblings. These are laws. Here, every state has its own law. So every country can adopt their own law when it comes to getting a consent for code status or undergoing different medical or surgical procedures. Another very important point that I want to raise, these are just random articles I have them here to support what I'm going to say. When we introduce code status, which is, do you want to have just compressions if your heart is to stop, or do you want to be on a machine if your breathing gets worse? When we do those discussions, it should be the discussions need to be very frank, that every just compression that we do doesn't bring back that patient. So the American Heart Association actually recommends that if someone is hospitalized, okay, because the chance of being revived after a CPR, after you're hospitalized, actually is lower. So you have to have this frank discussion with your patient, stating that 1 in 6 patients actually, after undergoing CPR, will come out of the hospital alive, okay? But just by having this frank discussion, you will save a lot of patients from unnecessary CPRs and unnecessary stay in the hospital in long-term facilities, trying to come off a tracheostomy and undergoing feeding tube placements. Let's just be frank with our patients, stating to them that chest compressions, yes, they are very beneficial, but when it comes to hospitalized patients, because we anticipate that majority of our hospitalized patients do have an underlying disease, which is hypertension, could be diabetes, it could be kidney disease. The number that we're looking at is only 15, which is 15% of those people will make it out of the hospital. And again, this paper down there indicates that actually less than 2% of those who have advanced cancer after undergoing resuscitation will actually survive, okay? So the number goes lesser and lesser once you have an advanced diagnosis, which is like advanced cancer or end-stage renal disease. But even for your regular patient, using this 1 in 6 number is very important. And it is recommended by the American Heart Association. Okay. I'm just making sure that I'm not missing anything. Okay, good. So very important. Yeah, of course, very uncomfortable, but very important friendly reminder is life is a terminal condition. You know, we all are going to pass by the end. And again, doctors are horrible predictors or prognosticators. There are a lot of studies out there, especially if someone has a relationship with that patient. If you diagnose that patient and has been seeing them in clinic for a long time, somehow you tend to think that they would live longer than they would. So doctors are horrible prognosticators. Us as medical professionals, when we give estimates, don't try to quantify someone's life. It's really not recommended to give, you have 8 to 12 weeks. It's really not recommended. Again, we're humans. It's good to give framework. I mean, of course, we have the medical knowledge and we can make that assessment. So it is recommended to say you have days to weeks, weeks to months, and it could be months to years rather than just putting a number, because the numbers are actually driven from research, which indicate that only 25% of those people lived this way. And we don't know if our patient would lie in that bell curve or outside of that bell curve. So it's better to give those estimates in terms of days to weeks, weeks to months, and months to years. So yeah, this is what this is saying is, and you can read it, is let's be as comfortable as possible for the duration, of course, and let's try to take the pain out of these conversations and talk about the unmentionable, you know, ignoring serious illnesses, ignoring discussion about a stage 4 cancer while someone has it won't make it go away. So it's actually much easier. It's actually much easier if we frankly discuss with our patient that, yes, you have a terminal diagnosis. And I think at this point, you would benefit from symptom management rather than undergoing an aggressive care, which would add more suffering to what is going on. So why do organizations benefit from palliative care? I mean, what do they benefit? Because as an organization, as a healthcare system, there is a strong evidence that palliative care improves quality, patient satisfaction, and cost. It's appropriate. And there's cost appropriateness that comes along with it. There are very few strategies that actually simultaneously improve your quality, the quality of care that you provide to patients by reducing spending. Because most of the strategies that trying to raise quality, you actually have to spend more. And with using palliative care services, like I said, it doesn't have to be necessarily physicians. It can be done by nurses. It can be done by chaplains. It can be done by social workers. Working as a team, you can actually reduce spending, okay, by improving quality of care. So different organizations should have an interest in having palliative care services under them. Again, these are studies that are based here. You can see 66% reduction in symptom and stress. That is very important, and thereby increasing patient satisfaction. And patient satisfaction is actually a quality measure in different healthcare systems. So improving patient satisfaction is, it's very important. So when you do it in an inpatient setting, so if you're providing palliative care in an inpatient setting, you reduce readmissions, okay, by almost 50%. And if you do it in an outpatient setting, which is if you provide palliative care in a clinic setting, if someone has a cancer clinic and alongside it has a palliative care clinic, if your advanced cancer patients see the palliative care physician, the chance of those patients actually going into the hospital significantly decreases. So as a country or as a healthcare system, you can see how significantly it reduces cost. When you go to skilled nursing facilities, these are places where the sick, the elderly reside for a long time. So when you provide palliative care services, hospital transfers, okay, because you have had that discussion that this patient has a shorter life, has a serious illness. So family or the patient themselves would decide that if I am to get worse, leave me where I am. So you are reducing your hospital admissions. And when you provide it at home, okay, when someone gets pain management and non-pain symptom management in a home setting, their chance of going into the hospital, okay, to get aggressive care significantly decreases. And that is, it decreases your total cost by 36%. So where can we provide the services? Again, inpatient palliative care nurses, inpatient palliative care, physicians can make rounds on admitted patients, and they can make determination. They can have these discussions that I talked about, manage their symptoms, have an advanced care planning, do goal of care discussions with their patients. So it can be provided in a patient setup. It can be provided in a clinic setup, okay? People can go to a palliative care outpatient clinic and receive these services, and they can be provided at home. There are people who don't want to go to a clinic or who don't want to come to home. That is just it's very tiring to go back and forth to hospitals or clinics. For these kind of patients, you can provide the services at home. And again, if there is a nursing home, you can provide it in a nursing home setup too. So what is the difference between palliative care and hospice care? They are different. Yes, of course, they are in the same continuum as we saw previously in that diagram: curative care, palliative care, and then hospice care and bereavement. Palliative care can be given concurrently with aggressive care. You can keep getting your dialysis. You can keep doing all those things while someone is managing your symptoms and while someone is discussing with you your goal of care, having things clearly laid out. And it's appropriate regardless of your goal of care. You can either decide, no, I no longer want treatment, or you can say, no, I want to keep having those treatments, and you still can get your palliative care services. It's not a Medicare Advantage, which is like here in US, after you hit the age 65, everybody, you will qualify for Medicare benefits, and it's not a Medicare benefit. So, but hospices, that's a major difference. If you are practicing in US, this is an important thing to know. When you come to hospice, when someone enrolls in hospice, that what we're saying is, with what we know and what we see right now, this patient has a life expectancy of 6 months or less. Yes, of course, they can outlive that 6 months and they can be reapproved for another 6 months service. But they can't keep continuing their aggressive care, which means they can't keep getting their chemotherapy, they can't get radiation, they can't keep seeing their other doctors. Once they're hospice care, what we're focusing solely is just on symptom management. So that's the big difference, okay? Palliative care, you can do everything else, okay? Hospice care, we are saying that you are at a point where your prognosis is 6 months or less, so other treatments need to stop. It's just symptom management. Yes, we don't want you to suffer, and that is our priority, preserving your quality of life as the end happens, and also making sure that your family understands what is going on and they are psychosocially supported, you know? So this was an eye-opener for me, because you have these patients that you see in a hospital, in the emergency room, very recurrent admissions. And when you see the patient, would you be surprised if that patient passes in the next 6 months? And most of the time, sometimes probably 60% or 70% of your patients, your answer is going to be, no, I won't be surprised, because these people have a lot of comorbidities. They have multiple comorbidities. Sorry, I'm getting some hands raised. Yeah, I will answer questions by the end of our discussion, okay? So if you're not surprised by the fact that this patient will have a life expectancy of 6 months or less, so why not provide hospice services? Why not consider hospice services? Of course, like every diagnosis has a specific criteria to qualify for hospice care. So just because you have end-stage renal disease, you're not going to qualify for hospice, or just because you have COPD, you're not going to qualify for it. There are distinctive criteria that you have to meet, but at least having that consideration that, okay, this patient is coming back to me multiple times. We're not really doing much to cure the underlying disease, and I don't really think it's curable. And at this point, I think the patient will pass in the next 6 months and consider hospice, okay? And of course, you have to tell them that they are foregoing treatment. They're not going to receive, let's say, surgery or chemotherapy or radiation once they enroll in hospice. So what's the work of the hospice team? Of course, they develop a plan of care, and their focus is managing symptoms, and they attend to the emotional, psychosocial, and spiritual aspects of the dying and the caregivers. This is very important. And that's why we need our chaplains and social workers, especially going out to people's houses and, you know, managing their symptoms and embracing the family as a family while they're caring for their dying loved one, okay? And then the hospice care team actually teaches the family on how to do things, because people are could be bedridden, you know, there's just a lot to take in when you're a caregiver. So the hospice team would provide those teaching. They would provide teaching for the family, okay? And then they would try to advocate for the patient and family, and provide bereavement care and counseling. You know, it's very important. Once you lose your loved one, there's, you know, they say like grief actually comes in waves, okay? And you need that extra layer of support, someone giving you a call, checking on you, checking on your well-being. And the hospice care team actually follows through after that patient has passed away, follows through with a family to see how they're doing, you know, usually up until 13 months after someone's passing. We're almost done. And here they are inpatient hospice facilities, and I hope we come to that in our country. They're not long-term facilities, but sometimes there are symptoms that come at the end stages of life. There is pain that is very difficult to manage at home, because at home we usually manage through oral medications. I know they come in liquid forms, and you just have to use a tiny beat to manage some, because they're very concentrated. So you just have to use like very small mLs to manage symptoms, but there comes a time where it becomes very difficult to manage those symptoms. When that happens, there are these inpatient centers where you can go to, get admitted to. If the patient passes there, fine. If the patient doesn't pass, we want to make sure their symptoms are controlled, and then they can be transferred back into their home setting, okay? And sometimes when all falls short and when we don't have facilities, inpatient hospital beds can be used as hospice beds, okay? Where these managements are being delivered. Yeah, questions? Again, majority of the slides and the facts that I used, they come from my training here, which is solely US based, like I said, and Dr. Ashanafi Beza, and then Salamoit Salamon, they will tell us about the Ethiopian piece of it, what has been started there. And I think I'll leave the floor for them. You guys can unmute yourselves. And then I think at the end, I will go through the questions and we'll be answering the questions at the end, okay? You guys can unmute yourselves.
Thank you, Rari. I think we had a very interesting lecture on palliative care, on the basics. And my part and Salamite's part will be just to show some about the practice of palliative care in our setup. We had 10 years experience in the health system. Palliative care has been given an attention. Before that, there was no major things done on palliative care. When we were medical school, palliative care was just part of one of the topics that we read on some of the diseases. When we talk about the prognosis, need of palliative care was one of the intervention listed in the in most of the medical care or surgical care, most of the prognoses. But in the health sector, it's only the last 10 or 12 years history. So Salamite will start and she will come up with the introduction and what has been done. And I will follow up with assessments, findings, and final next steps with the Ministry of Health working on palliative care. So what are things we are going to do in the coming years? So I will invite Salamawi to join. I think you introduced me well. So I'm a pediatrician, practiced in 5 years or more than that. And then I joined Ministry of Health. I was a Director General for the Minister in Ministry of Health for about a year. Then I joined the medical services to assist and as a technical advisor. So I'm working on different initiatives, and one of it will be palliative care, but I have had in other specialties and specialty service improvements. I'm working on clinicians, on some initiatives and programs which works on clinicians, and we are working in clinical leadership program and many other things in our directorate, which is the clinical service directorate. So it would be enough for me to introduce myself. Let me invite Salamite to go on the slides and I will continue after her. Thank you.
Thank you, Ashay. Okay. Just try. Can I share my slides? Ashay,
I'm sharing it. Shall I?
Write this on your part.
Okay. Okay. You can continue now, Sharon. You can share now, Salam.
Okay.
It's coming.
It's not coming.
I can share it and I can take the slides for you.
Okay, okay. If you can
Shall we
share
go?
it for me. Yeah,
Let me go.
just make it on my part
Okay.
so that I can make it on
Here.
the first slide.
Okay. Here it is.
Thank you very much. I'm Salamawit and I'm National Palliative Care Coordinator. So we are going to, I think the slides are not seen yet. The introductory slide.
Is it visible? Ready?
No, I don't think it's visible. It's on page 9.
Yeah, can you move it to page 1?
Okay.
Yeah.
I have to stop sharing.
I am using your ID, that's why I'm not
Okay.
able to share.
I actually have the PowerPoint if you guys want me to share it.
Yeah, if you can.
Yeah, sure.
I'm
It's okay. Not a problem. Share.
here. Now visible?
No, it's not. Yeah, it's visible.
Yeah, okay.
But I cannot use the slides.
It's okay. I
So
will.
you help me to, yeah.
No problem. Just tell me to move it to next page and I will. Okay.
We're going to present the palliative care practice in Ethiopia and the introduction, the milestone and current progress will be presented by me and Dr. Ashanaf to present the challenge for conditions and the next steps. On the introduction part, as we all know, palliative care, especially the burden of NCD, is increasing. Almost 57 million patients and families need palliative care annually. In this need, only 7 million patients and families globally got this palliative care service in 2017, and it's only 12% of the national need. And we are expecting palliative care need by 2060. It's about to increase by 87%. So we are working day and night on palliative care. That's why we're doing everything on palliative care by now. So in Ethiopia, there was no cancer registry until 2011, but in the 2019 Gregorian calendar, we got different researches. The research was done by Solomon and Mugeta, and on that research, it was there was 3 top cancer cases in our country. The first one was breast cancer, and it is almost about 30.2%, and cervical cancer is 13.4%, and colorectal cancer is 5.7%. Almost 43% of our cases are occurred in women, and for kids, there was also the research results. Almost leukemia and lymphoma is common in Ethiopia. So, and also there was research done by UNAIDS, so that almost 690,000 people are living with HIV/AIDS, and they are dying. Almost 11,000 patients are died with AIDS-related disease. So I'm just going through these researches because how much palliative care needs in Ethiopia is very important. And also Lancet shows NCD is increasing. It's almost about 52%. So we are establishing different palliative care services, and it was very challenging because especially the community and healthcare providers are not that much aware on palliative care service, and also we're planning to work in collaboration with government stakeholders, especially on health professionals, because health professionals are game changers. Because if you are working on the awareness of health professionals, it's very easy to implement palliative care service. It's so easy and it will be fast, I think. On the next slide, our goal is just to scale up and implement policy-based Ethiopian lead model palliative care hospitals, but it should be accessible and evidence-based quality service. And we'll do more on drug availability and education and research. And on the next slide, it is about the milestones in Ethiopia. And before I'm starting in 2010, in 2003, I think, Gregorian calendar, Sister Gereda, the first person to introduce hospice care. She was learned, I think, in Uganda, and she was passionate and formally advocate palliative care in Ethiopia and establish hospice care in Ethiopia. And it was not known in Ethiopia that much. And after 7 years of this palliative care service established, in 2010, NCD prevention and control framework strategy was established. On that time, palliative care for the first time added in this strategy. After 5 years, I think, 2015, this national NCD action plan was developed, and palliative care was part of this action plan. And on that time, pain management training module was developed. And on that pain management training module, one part was palliative care. After 2 years, after 1 year, it got a little bit attention, and Ethiopian Hospital Transformation Guideline was established. And in that guideline, it has 20 chapters. And the 13th chapter was palliative care, and it's included in this national guideline. And it was having an attention. And also in 2017, palliative care guideline was developed that you are seeing on the slide. That's our guideline. And after that, we are working on it. And so in 2017, primary health care guideline was developed. And in that guideline, the pain management part in the palliative care service is somehow palliative care, but more of pain management part was included in this guideline. And in 2020, palliative care drugs are counted as unessential drugs, and it's included in the guideline, which is the essential drug list, so that palliative care is part of these essential drugs. And in 2021, thanks to our directors, it got a lot of attention, and we got a strategy, and we're having training manual for palliative care service, and also pain management guideline also developed nationally. This was the milestone, and what was done on the implementation. Pain-Free Hospital Initiative was a flagship that was very helpful to introduce palliative care. Pain was considered as a fifth vital sign, and we're giving different trainings for almost all hospitals, and we are giving 2,208 health professionals, including doctors, pharmacists, nurses, and social workers, were all involved in this training, and the introductory part of palliative care was merged on this training, and everybody has a training, and mentorships, experience sharings, and different activities on palliative care was done by last year. And we are planning to create 6 model hospitals, and we are giving different trainings, different materials, the supports, mentorships, and supportive supervisions. And we got 4 model hospitals. By now, we are adding 1 model hospital, so we are having 5 model hospitals working on the palliative care service in 2021. And for your surprise, we have community-based care teams. They are working for free. They are not paid, but they are volunteers to give home-based care for palliative care patients. And these 3 hospitals are St. Paul, Warabi, and Hawassa. And they were having experience from Hawassa, and they bring to them. They are not paid, but they are working. I need to say thank you for these hospitals. On the next slide, we're doing on drug. This is very challenging area. Without having morphine, we are not saying we are giving palliative care. So morphine syrup especially is very, very difficult. We have shortage on morphine syrup, but previously were manufactured in the country by IFAR in 2010. And currently we're having a team, we're establishing a team to initiate this production. It was not sustainable because of different issues, and we're just making things to happen so that we can avail all drugs, especially morphine, sustainably. Next slide. We're also working, as I told you, we're working on the training more because it's good to aware professionals because they can advocate more. They can be a speaker for the patients. So we're giving 3 days training on pain and palliative care course. We're giving this training because we're using pain-free hospital initiative budget because it has no budget for the last almost 4 years, and we're having budget by this year. But for the last 4 years, we're giving this 3 days training, and 1.5 day was given for palliative care introductory part. And we are working on the on-site training courses because we can get more professionals on site. We're giving almost 25 professionals in one hospital, and we're having more advocacy, more professionals in one hospital to speak out about palliative care and to give this service. And also we are having social worker trainings for 3 days, and we are giving for different hospitals these trainings. And we also included, I don't know whether I said, we're working on different sites, like we will have one hub, and the patients will be referred to this hub, or otherwise we are doing by on call, and outpatient will be there, and the community service will be incorporated on our setup, and also the health extension practitioners will refer our patients to the palliative care hubs. We are working like this. So the health center training is very important, so that we are giving training for health center staffs and health extension workers. And also palliative care in children was giving with a separate of adult training, and we're giving this training frequently. Especially now, we're having a new module it's almost approved, and we're using that module. It's for 6 days, and 1 day is for practical session, and 5 days was for lecture, and we're giving this training almost for 245 professionals, and I think they're aware of this. And we're working on advocacy on different parts, like we're celebrating Palliative Care Day for the first time in ministry by this year, and we're trying to advocate palliative care service so far. We're doing this all. Thank you very much. And the challenges and other experiences and mentorship findings will be presented by Dr. Ashnafi. And thank you very much.
Thank you, Salama. Dr. Ashnafi.
Thank you. Thank you all. I will continue with what Salam has started. My part will be very brief and to give some challenges that I'm also accepting questions related to hospital practices from in the question and answer part. So I will try to reflect some of the hospital assessment findings in palliative care. So as Reddit previously explained, the strengths of palliative care service delivery in US and in our setup is very hugely different. And in our setup, a lot of challenges have been mentioned, and we are really challenged with different areas. One of the areas is to have the actual awareness on palliative care in the community as well as in the healthcare providers. The other part is to lack of adequate medicines for palliative care, especially on opioids that Salam was explaining. The third part is the lack of availability of human resource in palliative care. So these are the major areas of gap that we have identified. So this has been included in the recent 5 years strategy on palliative care that will be launched in the coming weeks to the public. It's already endorsed in the ministry and it will be launched. So when we have palliative care service improvement in hospitals, we have had a lot of visits to hospitals, and these are just the most of the findings, common findings in hospitals. One of the common finding is healthcare providers and also hospital leadership doesn't have a commitment, or they are not committed to establish palliative care service and also strengthen the service in the existing in the hospital. And we have been asking to arrange a different clinic or space, one office or two-roomed office for palliative care, so that we can at least work on the hospital-based palliative care. And most of the responses are lack of area, commitment, and payment for the physicians or incentives. So we don't get adequate responses from the hospital leadership. So this is one of the challenges. The other one is among the ministry, when we have in 2016, we had the Ethiopian hospital service transformation guideline was prepared, and it has 20 chapters, which in each chapter, some of the service areas were included, like chapter 1 is about medical record rooms, chapter 2 is about outpatient service, and in chapter 12, palliative care and rehabilitation service were merged together, and people got confused in this concept. So most of the hospitals doesn't have a specific palliative care service to be given in their facility, but we found them to deliver physiotherapy and the rehabilitation service, and they merged palliative care in it, and there was misconception on it. So this was one of the challenges in our hospital. The third one is the palliative care practice and understanding among the healthcare professionals is quite inconsistent. So even despite their level of specialties, palliative care were not understood symmetrically. So there were challenges among the nurses, health officers, general practitioners, and also including specialists. So we don't have adequate undergraduate program. The integration of palliative care in their curriculum may not be adequate. So that would be the reason for these findings. The other finding we got was there was no, as I mentioned previously, there is no palliative care specific designated area in the hospital. So that was one of the recommendation, but it doesn't happen most of the time. So as mentioned, 3-4 hospitals have taken palliative care seriously, and we have seen good improvements. The other one is palliative care service is not followed properly among the regional health bureaus and also other health districts as part of the care. It's not, most of the thing is part of their supervision. So these 4 major areas. One is the attitude part on palliative care practice. The budget allocation palliative care service is not adequate, as we see the shortage in medicine, especially of opioids. The other is there is no curriculum for MPH or PhD fellowship in the country on palliative care. So as we see already, it is specialist in palliative care specific. So we never had those type of professionals in our country, because the higher education as postgraduate program is not yet started. Only the nurses have been trained on palliative care. That's what we have at Black Lion Hospital, but we need to work on that seriously. The other is partners' involvement, engagement is not adequate. Next. So what are we going to do in the coming years is to support and to improve the supply of medicines and resource for basic pain relief. So this will be one of our priority areas. The other one is to strengthen and model pain and palliative care services for selected hospitals. So we may have we select hospitals at different sites, and we differently support them to be models on palliative care service. The home care standard and home-based care to be given will be strengthened. The advocacy part is lacking, so we will be working on medias, and awareness on palliative care will be done at leadership level, at community level, and health care providers level. We'll monitor palliative care service in the nation in the different sites of hospitals. And in the final one will be to specifically support the local production of morphine in the country. And also in the curriculum part, we will work on under and postgraduate programs on palliative care to be included, and some of them to be initiated as postgraduate courses, so that we may get more human resources to give the service in a coordinated manner. The other very important one to work on will be to coordinate and support experience sharing on palliative care practice among the local facilities, and also international experiences would be considered, and Ministry of Health will focus on that. Thank you. The next one that will be my end of presentation. If there is any question and reflections, we'll respond. Thank you very much. Because I don't have a clear video, that's why I didn't show the video part. Thank you already. Over to you.
Shanafi. Thank you, ሰላማዊት። ጥያቄዎችን ለማየት እየሞከርኩኝ ነበረ። I think some of it ነክተዋል መሰለኝ። residency program አለ ወይ በፓሊያቲቭ hospice care training interested ነኝ የሚል ጥያቄ አይቻለሁኝ። I think that's part of the plan አይደል?
Yeah, it's part of the plan. ግን ያው currently ምንም አይነት እንትን አልተጨመረም፣ ግን by next year ለእንትን MPH እና PhD level training እንዲሰጥ already training ሞጁል አልቆ ጥናሳ ኢምፕሊመንት ሊደረግ ነው። so that ከዚህ በኋላ የጋራ አድርገን የሁሉም ሴክተር እናደርገዋለን፣ ሁሉም ዩኒቨርሲቲ ላይ የሚሰጥ ኢንተረስትድ የሆነ ዩኒቨርሲቲ so that ከዚህ በኋላ እንድንጀምር። ግን ፋሚሊ ሜዲሲን I think part of የሆነ ፓርቱ ፓሊቲቭ ኬር ነው እና በዛ መንገድ አድሬስ እየተደረገ ነው እስካሁን ድረስ ፋሚሊ ሜዲሲን ተማሪዎቻችንን ነው ለፓሊቲቭ ኬር ሰርቪስ እየተጠቀምንባቸው ያለ ነው እና ሜቢ በዛ አድሬስ ማድረግ ይቻላል ግን እንትን እንደዚህ በትል ሌቭል ገና አልተጀመረም ካሪኩለም ውስጥ እናስገባው እየሰራ ነው።
አቴንዲዎቹን ጥያቄ ካላቸው ራሳቸውን አንሚዩት አድርገው እንዲናገሩ እንትን ያልኩኝ ነው አላው ያረኩት ነው። ስለ ጥያቄ ካላችሁ ዶክተር ምትኩ I see one hand raised. Okay, Dr. Mulgeta ራስን አንሚዩት አድርገህ ጥያቄ መጠየቅ ትችላለህ።
Okay, thank you for the presenters, Dr. Adait and Dr. Ashanafi Salamawit. Yeah, it was an interesting presentation for me, and basically, like the palliative care issue in our country is almost like I can say it's neglected. Like last time I was talking to Salamawit about this issue when we had a phone conversation. I'm basically a hematologist oncologist, pediatric hematologist oncologist, and we are here struggling to get even a team who can work on palliative care, and then the drugs are not consistently available, and it's kind of like it's mostly considered as secondary. Like so I was talking to her because I heard that they are working in some selected hospitals in the country, but in our university hospital, in Gondar University Hospital, where there are adult oncologists and pediatric oncologists, the care is almost non-existent. So I think it's better to work in collaboration so that we can create awareness. I remember that there was like a specialty program, hybrid program on palliative care, and they were recruiting for interested staffs. I don't know what happened to that, but still we need to know what's going on, and I think they have to come closer, and we need to work hard so that we can make sure that patients are getting the appropriate palliative care.
Yeah.
Shall I respond?
Yeah, you go ahead and then I'll have it.
Thank you very much, Dr. Mulgeta. That was a very good insight, and we have prepared the 5-year strategy on palliative care.
Not a question really, but I just want.
Yes, I got your recommendation, and I'm going to reflect on that. So considering the strategy, so there are 4 major areas of the strategy to be implemented in the coming years. So it will be followed accordingly. So the first one will be on the clinical service, so on the palliative care practice improvement. The other one will be on education part, so it will be the second priority. The third one will be on awareness creation on palliative care. And the last one will be doing on research on palliative care. So these 4 major areas are part of the strategic documents. That means we'll be working on these 4 areas in the coming years. So we'll reach all hospitals, all facilities, will consider improvement in palliative care. Also, we'll try to consider the training part as you recommended. We'll check on what has been the progress previously. But from now on, as Salam explained, we are trying to engage family medicine specialists. Training on palliative care to be initiated at different universities, and we'll work on to engage on that, and we want to make palliative care as an actual practice in our setup. So we have a lot of challenges. We'll work together to improve it. Thank you.
Yeah, to say a little bit about, I mean, wherever you start, you're going to have limitations. Whether you're in a resource limited country or like in a resourceful country, you will have limitations. But the beauty about palliative care is, unlike other specialties, I mean, you can name others. For example, in nephrology, for example, if you don't have a dialysis machine, you don't have a dialysis machine. But in palliative care, there's a lot of compassion. Like, you've been trained as far as you've been trained. Of course, I'm not denying the resource limitations when it comes to medication, staff limitations, training limitations, awareness. Those are very important areas where I think Dr. Ashanafi and Salamait have, laid out the plan they have for our country. And being trained as much as you've been trained as a pediatrician, as an oncologist, or as a primary care physician, to have that compassion and you have a better medical knowledge when you compare yourself with the patient. So to lay out and to communicate with your patients what their diagnosis is, what stage are they in? For example, it could be a tertiary hospital. I mean, it could be in a rural area. I practiced in Jinkana. When I practiced in Jinka, I remember, like, there were patients that used to come to us with stage 4 hepatocellular carcinoma, like HCC. So for those patients, to actually recommend them to come to Black Lion, it's very saddening. I know for a fact that ቤታቸውን ሽጠው ያላቸውን ፋሚሊ ሰፖርት ያለውን ነገር like ቤተሰቡ የሚቀጥልበትን ሪሶርስ ምንድን ነው የሚባለው አፍርሰው ወደ ብላክ ላይን ከደረሱ በኋላ የሚያገኙትን ኬር እኔ አውቀዋለሁኝ ከነሱ የተሻለና to sit down and tell them, yes, it's very sad that you have this advanced disease. At this point, I think you would actually benefit from pain management wherever you are, okay? And not to have that heart-to-heart conversation with your patients is the beginning. And again, I'm not trying to deny your resource limitation. Again, we are where we are now. With what we have, what can we do? Okay, I mean, there could be medical students watching us right now. There could be GPOs or like specialists. We all are actually, when you think about it, we all have palliative care skills, which is okay? It starts from there. And then some sort of palliative care practice እናደርጋለን pediatrician minhun, internal medicine surgeon minhun, pain ሲላችሁ በሽተኛችሁ ካከማችሁት, you're doing a little bit of palliative care, okay? So I think we can do የተወሰነ part. And again, of course, resource መሞላት ያለበትን while we're working on it, let's just do what we can do. Another question is, እኔ ያለሁበት ቦታ ሊዲያ ስጠይቀኝ ነበረ ቀጥታ ከሜዲካል ስኩል ሳይሆን internal medicine or family medicine residency ከጨረሰ በኋላ ነው ሰው palliative care መማር የሚችለው።
Fellowship,
yes. And then እዚህ ጋር ሌላ እጅ ያነሳ ሰው ፍሬው አስራት ራስን አሚዩት አድርገህ መጠየቅ ትችላለህ።
ፍሬው በደንብ አይሰማም፣ ምናልባት ኮኔክሽን ሊሆን ይችላል። You can text us on the question and answer part. Sorry, Freo.
someone አይደለም።
የኳሊቲ ችግር ያለ ይመስላል። በደንብ አይሰማም። ምናልባት question and answer ላይ ብታስቀምጥልን we can respond, or in the chat box ላይም ትችላለህ ፍሬም። In the question and answer, the question is from Mikias, why don't we start subspecialty training in Ethiopia? Milala, I think I can answer this live. Am I heard?
Somewhere.
Okay. Now Yeah, it's a good start beyond. So considering the palliative care, በቂ የሆነ training at different levels መሰጠት አለበት ብለን እናምናለን። palliative care at subspecialty programs ውስጥ የለም listed ከሆኑት። So you know our country's limitation እና በዛ የተነሳ we may not do it right now. We have now national specialty and subspecialty service roadmap. So that service roadmap have prioritized some of the interventions, some of postgraduate and subspecialty level that the country needs. Among that, specialty in palliative care is not included. This could be, this may not happen in the coming years, but it's important. I believe palliative care is important to be included in the specialty. So we may consider it in the coming years when we are a low middle income country who have resources for specialty and subspecialty training. So that could happen after this strategy is well succeeded. So among the basic specialties, we are including some of subspecialties as a program nationally, and palliative care is not part of that. Thank you.
ሜቢ ሌሎች ጥያቄዎች የተነሱ አሉ ላይክ የፕሬዘንቴሽኑ የጋይድላይን ሁሉንም ኮፒዎች ሼር እናደርጋችኋለን አይ ቲንክ በሆነ ሚስ ግን ሜቢ ቅድም ዶክተር ረድኤት በደንብ ስትል የነበረው ፎከስ እንዲደረግበት ምክንያቱም ኦልሞስት 37 ፓርቲሲፓንት ያለው ሜዲካል ዶክተርስ ላይ ያሳብን የነበረው ያን ያህል ፓሊቲቭ ኬር ሪሶርስ የሚጠይቅ ነገር አይደለም ከሜዲኬሽን ውጭ እና ብዙ ጊዜ ትሬኒንጎቻችንን ስንሰጥ ምን ነበረ ሊሚቴሽን በጣም ያስቸግረን የነበረው ሜዲካል ዶክተርስ ብዙ አይሳተፉልንም ትሬኒንግ ውስጥ ዛት ዴር ማኔጅመንታችን ላይ በጣም ችግር ይገጥመናል ምክንያቱም in our country prescribers are doctors or health officers ስለዚህ ነርሶችን ብናሰለጥን ፔሸንት ፔን ማኔጅመንት በተለይ በጣም ነው የምንቸገረው እና በጣም ደስ ብሎኛል አድሬስ ያደረግን ያለናቸው እነዚህ ሁሉ ሐኪሞች ፓሽኔት ሆነው ዛት ከዚህ በኋላ palliative care ትሬኒንጎችም ሲኖሩ or palliative care ሰርቪሱ ላይ ኢንጌጅ ማድረግ ሲኖርባቸው ኢንቲግሬትድ ሆነው ላይክ በጣም በራሳቸው ቮለንተር አድርገው መስራት ቢችሉ ዛት ቀደም በደንብ አክኖሌጅ አደረግ የነበረው እነዚህ ሆም ቤዝድ ኬር የሚሰጡ ሐኪሞች በራሳቸው ተነሳሽነት ነውና የሆነው ግሩፕ ትሬኒንግ ጋይ ያለ የሆነው ግሩፕ ግን እንደዚህ ሆም ቤዝድ ኬር እስከመስጠት ድረስ ፓሽኔትድ ሲሆን palliative care ሰርቪስ ለሁሉም ለኢትዮጵያ በሙሉ በደንብ አድሬስ ማድረግ እንችላለን እና ፕሊዝ ያው there is something we can do ምን ሐኪሞች እንደሆነ መልእክቴን ለማስተላለፍ ያህል ነው thank you very much
thank you ሰላማዊት ሌላ ጥያቄ ካለ የመጨረሻ እድል ልስጥና ሰዓታችን እየደረሰ ነው
So in the chat box and question answer ላይ የተቀመጡ አሉ ይታዩሻል already probably we can talk about them like you can train residents የሚላለ I think we can make a training and awareness sessions on palliative care on different existing specialties trainings so palliative care in short course but 2 weeks or 1 week modality awareness መፍጠሩ በጣም important ነው we can work on that I think Salam is already ready to focus on this type of training what we were talking about was a specialty so that may not happen in the coming 5 years but after that we may consider it based on the capacity we have but the training part is you are right we will take it so we will share the documents too thank you Radi
PowerPoint-ን እንደ ፓነሊስቶቹ ቻት ላይ ሼር አድርጌዋለሁ whoever is interested ፕሬዘንቴሽኖቹን ቻት ላይ ሼር አድርጌዋለሁ
excellent and question and answer part ላይ ስለ bereavement እና ስለ Medicare benefit አበበ ሙልጌታ ያነሳው ነበር probably ready if you reflect on that
question I see here is,
Can you explain more about
Yeah.
bereavement and Medicare benefit?
where do you see that? Where do you see that? Okay, you explain more about, you read it for me. It's fine.
Okay, thank you, Dr. Reddit, for the interesting presentation. I
Actually,
learned a lot. Can you explain more on bereavement care
yeah.
and Medicare benefits?
Okay. Okay. So Medicare in general is, it's a type of insurance here in the USA. You will qualify for it once you hit the age of 65. Okay, so from your commercial insurance, completely your benefits will go into a Medicare benefit. Okay, palliative care is not a Medicare benefit. So if you keep seeing your doctors, you keep seeing your oncologist and your kidney doctor, you can still see a palliative care physician. But that would be from your commercial insurance. Okay. But when you're 65 and you enroll in hospice care, that is a hospice care benefit. Okay, that's a Medicare benefit. Okay, that's that. Bereavement care, it means አማርኛ ተርሙን አላውቀውም ግን የሀዘን ጊዜ ይኖራል አይደል? If someone actually if their loved one has passed away, if that patient is actually enrolled in hospice care 13 months after the death of the patient, bereavement care will carry through, will check on family members, because a lot of depression, a lot of mental illnesses actually follow after someone loses their loved ones. It could be a child, it could be your spouse, or it could be anybody in your family. So what bereavement care means is like so በኋላ 13 ወር ድረስ ያ ቲም ያንን ቤተሰብ ፎሎ ያደርገዋል። it could be በስልክ ሊሆን ይችላል፣ physically visit አድርጎ ሊሆን ይችላል፣ it could be psychological support ሊሆን ይችላል። ምክንያቱም ሰው በብዙ ነው የሚያልፈው አይደል? So just providing that support ነው። ሌላ አንድ ጥያቄ I guess the same አበበ ከጠየቀው እኔ ደግሞ ማየው which anti-pain medications do you recommend as part of palliative care, opioids versus NSAIDs? So እዚህ mainly pain እዛ level ሲደርስ pain associated with serious illness usually narcotics ይፈልጋል። Okay, ግን again I wish we could have another እንደዚህ discussion, and maybe we will have one day about pain management, because pain management by itself is በጣም ሰፊ ነገር ነው። It starts from assessing the pain. ምክንያቱም ሁሉም pain somatic አይደለም አይደል? አንዳንዱ pain is nerve pain, so nerve pain እና somatic pain በመለየት ራሱ አንዳንዴ as simple as gabapentin የአንድን ሰው pain ማከም ይቻላል። It just needs pain characterization ነው የሚፈልገው. Okay, so yes, of course you can use NSAIDs. Can as serious as the illnesses, and sorry background noise አለኝ, as serious as the illnesses, ብዙ ጊዜ ናርኮቲክ ነው የምንጠቀመው። ምን አይነት ናርኮቲክ? ዩዥሊ ሞርፊን ነው የምንጀምረው አይደል? ግን ደግሞ ሃይድሮሞርፎን፣ ኦክሲኮዶን፣ ብዙ አይነት ፓቾች አሉ፣ ኢንጀክሽኖች አሉ እና ያው as much as our resources allow ነው እንግዲህ ባለን በፎርሙላሪያችን ነው የምናወራው አይደል? And I think but serious illness ሲኖርህ usually you just use narcotics, and the start is morphine.
I have one point for you, probably. Shall I read it for you? And I don't anonymous attendee.
Is she?
Do you see that?
No, I don't.
How do you feel about euthanasia? Do you think giving narcotics is part of euthanasia? Double effect scenario.
Physician assisted death. It's euthanasia is not allowed even in US. Okay. Again, this is on a topic. In United States of America, euthanasia is it's a criminal act. physician assisted death ግን allowed የሆነባቸው physician assisted suicide ሚለውን ትተውታል አሁን physician assisted death ግን allowed የሆነባቸው ስቴቶች አሉና there are about አሁን I think 7 ወይ 8 ስቴቶች አሉ when someone has a very serious advanced illness a physician can prescribe them a medication. They can have the medication available for themselves and they can decide to take it or not. Okay. So that's not euthanasia. That is something else. Again, it's a very ethical issue. There's a ethicist ባለበት ብናወራ ይሻላል እንደነስ ነገሮችን እና the dose that we use, I know the dose that we usually use for symptom management in patients with cancer, they don't cause death, they don't facilitate or hasten death. There's that big misconception that respiratory depression with the morphine dose that you have to use is bizu, or like the benzodiazepine dose that you have to use is a lot. So there is a misconception that you are hastening death when you are actually treating someone's pain, okay? So again, I guess this is very broad, okay? I won't cover it with each euthanasia even here is it's a crime, it's not allowed, and there's something called physician assisted death, and that doesn't equate into hospice care. If that is where the misconception is coming, hospice care is using the tiny bit medication that you can use is treating someone's death so that they can have a dignified pain-free passing, okay?
And that's well responded. I think euthanasia, in a place where euthanasia is not allowed, we cannot talk about giving the palliative care, the dose of morphine towards euthanasia. So there is no discussion like that because it will be seen as a legal issue. So I think we are not in a position to respond while euthanasia is not allowed.
That's very true, yeah.
I think we are out of questions now.
Okay, good. Okay, yeah, I don't see any more raised hands. So Leslie, thank you participants. I guess, yeah, I think it was a successful presentation. I'm really happy to see, Ethiopia initiative. It's very exciting. Hopefully we will collaborate in the future and, have trainings because like I said before, it's a skill set as part of, it could be in residencies, in different residency programs, and it could be in medical education, incorporate with Derag and meet Thank you, Dr. Ashanafi Salamet. Thank you, Salamait Salamet Ashwadamna Masekanalan. We really enjoyed your presence and your presentation. And thank you, participants, for showing interest. It's a big topic. We will keep learning about it. And I hope you learned something. If you have completed this session, please, I have attached a link in the chat where you can go and fill the form and actually earn a credit, continued medical education CME credit. I have attached it just now again. So you can fill this form and earn your credit for your participation. Thank you again. Salam adaru Ethiopia.
Thank you, Radi, for the invitation, and we have enjoyed the experience. I hope we'll have more to meet.
I think በፔን ማኔጅመንት ድጋሚ እንገናኛለን። በፔን ማኔጅመንት ድጋሚ እንገናኛለን። በጣም ነው የምናመሰግነው ኢኒሺዬቲቫችንን በዚህ ልክ ፕሬዘንት ስላደረግሽልን። Thank you very much. ሁላችሁንም እናመሰግናለን። ባይ